Welcome to the Physio Insights podcast, presented by Run Easy. I'll be your host, Dr. Jimmy Picard. I'm a physical therapist, running coach, and team member here at Run Easy. On this show, we have real conversations with leading experts, digging into how we recover from injuries, train smarter, and use data to better guide care. Whether you're a clinician, coach, or an athlete, we're here to explore what really matters in rehab and performance. Let's dive in. Ben Lombard, welcome to the Physio Insights podcast. How's your day going?
Good. Thank you so much for having me. Busy day in clinic, but excited to have a chat. So we're really glad that we can make time work.
Yeah, as was I. And you came on my radar from the Run Easy team. You've been using Run Easy for a little bit, so I'm sure it will come up in the podcast. But before we go down that rabbit hole, tell me a bit about yourself. Tell the listeners about yourself. How'd you get into physio?
Yeah, so I'm a physiotherapist based in North London. I've been a physio for about 10 years. I got into physio kind of a classic route, I think. I had an injury as a child. I played a lot of sport growing up, and I actually went to see a sports therapist and did the whole sort of rehab thing. And at the end of that, I remember just being quite sort of enamored with sort of how he got me back from what I felt was kind of debilitating at the time to sort of normal sport and action. And at the end of my treatment course with him, I asked him, how do I do what you do? And he said to me that, actually the traditional route is physiotherapy. So go to university, study physiotherapy, and then specialize in something like sports injuries like he did. This is maybe 15 or even nearly 20 years ago, where he was a sports therapist, and they weren't so common in the UK at the time. And he advised me that actually, if you wanted to be a sort of like a more recognized person within the sort of fitness and wellness space, physiotherapy would be the route to do. And so I did that. Then I graduated in 2016 and then worked at a couple of different clinics in London before starting on my own in 2019.
Awesome. Yeah. So 10 years ago, you graduated.
Yeah.
A decade has passed. I imagine a lot has changed in the way that you practice or how you think about treating patients.
Yeah, I think actually the whole space has moved on so much in that time. I think people recognize what physiotherapists can do a lot more and sort of are more willing to sort of self-refer. And I think actually generally my practice, I've always been very exercise prescription and exercise based, but that has become more and more popular, especially over the last sort of 4 or 5 years. Now you're seeing so much crossover between sort of strength and conditioning coaches, PTs, physios. And I think that I've taken a lot of that into my practice, and actually especially the more that I have niched down into sort of dealing with runners specifically, and the sort of need for strength training to supplement and to sort of complement the running that people do. And actually in terms of rehab goals, right, we've moved on a lot from those sort of basic 3 sets of 10 reps with your band, and now getting people loaded much more. So that's definitely changed a lot about my practice.
Yeah, so before that awareness shifted to more exercise focused, what did it look like before?
I think it looked easier. There'd be maybe a bit more manual therapy stuff. Obviously, like the assessment and diagnostic skills, you really develop that over a long period of time. And I've always been size prescriptive, but I think that maybe I shied away from the sort of higher end work rehab stuff. And, I sort of saw myself more as a bridge between. So identifying someone's problem, helping them understand it, beginning their journey of rehabilitation, and then sort of shuttling them through towards someone else to take on the sort of higher end rehab. And that sort of came because one of the places that I worked, we sort of had that facility within the clinic. We had physio, we had osteopath, we had a couple of other bits and pieces, sports massage. We also had like a rehab person, and we sort of worked a little like a through flow. You kind of like, you see your physio, you kind of understand, get the journey started, and then you sort of effectively graduate onto those sort of harder things. And whereas now it's much, physios now, and maybe, over the last sort of 5 or 6 years, have really begun to take on a lot more of that.
I see that in the US as well, where when I was a student, when I can remember, one of the clinics I worked at had what they called like post-rehab. And it was as soon as the patient got a little bit better and you could move them on, and they left physical therapy and they went to post-rehab. And that's where they got to do all the fun stuff. We had to deal with all the hard part. And then the fun stuff they got to go do with the S&C coach or the athletic trainer.
Definitely, and I also think some of that was actually slightly intentional by the owner of the clinic. I think the idea was there wasn't many of us at the clinic, and we were quite busy. It was trying to get as many people through as possible. So, I think some in their mind a little bit was, why would we spend the additional time getting the patient above and beyond with you when your time potentially better for the business to bring in more money if you are sort of assessing the patients and then distributing them on almost kind of like, here's your physio, this is your consultation, and then triaging them to sort of what they need, maybe some soft tissue work, maybe, some physio with you, then on to the higher end stuff.
Was this one of the reasons that pushed you to start your own practice?
Yeah, big time. When I worked within a clinic, you could sort of see the business side of it a bit more. And I think that detracts a little bit from what you feel like in terms of your autonomy for what you feel like you can do as a physio. I felt that I just had more that I wanted to do with my patients. So that's what led me to take the step towards working on my own terms. So, I could see the patient as many times as I wanted to, and I could then get a bit more involved with the sort of actual return to sport and the sort of progression from there.
Would you describe your practice style as like all the way from injury to full performance, that whole spectrum?
That's the aim, yeah. I like to pick up someone who's injured. I like to nurse them back to sort of full health, and then sort of, if I can tack onto that some sort of performance goal, that's what I really enjoy. And that is something that I particularly enjoy with runners, right? And I think that it's something that you often see, someone who's been dealing with a stubborn injury and you help them over the injury and you get them back into running, then, they decide to start training for a race. So they might, it might help them with some coaching, and you'd certainly help them rehab to sort of facilitate the training that they're doing right the way through up to race day. Yeah. I love that sort of whole journey. It's like almost like the element of task completion. And I think in a lot of jobs and a lot of facets of life, you don't get the task completion. So I think for me, I like to complete the circle.
I'm just curious, what made you niche down with runners?
Running became something that I was personally enjoying. So, I mean, I used to work in London, right in the city. So you used to see a wide variety of patients, and you would see some runners, but you'd see a lot of sort of like desk-based work and a lot of gym goers. But actually, I got into running myself, and it's a fairly small circle, especially a while ago. It's grown enormously now, but once you start doing some running, maybe you go to the odd run club here and there, you chat to people, say you're a physio, and see one runner, then they send you a few, and it just started to sort of, it was quite like a natural evolution. And my caseload just became more and more running focused, and I went on a couple of CPD courses. One really good one by Tom Goom. I did his running repairs course in like 2018 maybe, or 2016, 2017 maybe, and I really, really enjoyed that, and then just was able to combine my passion for the sport and like seeing more runners. And I think there's a little bit of almost like social proof. I think people quite like the fact that I was a runner as well, and it just became, you just start picking up more and more referrals, and I just kind of went headfirst into it.
Yeah. So I was going to bring this up later, but since we're on this topic, you're a runner yourself. You've built a business around treating runners. Do you feel like it's necessary to be a runner to treat runners well?
No, you absolutely don't need to be a runner to treat runners well. And there's loads of examples of non-runners who are fantastic at dealing with runners. But what I will say is that I think it gives a little bit of added context and understanding to what your runner is feeling, the demands of the sport, whether it's training sessions, whether it's injuries per se, whether it's like races, having completed marathon blocks or 5K blocks, and I think that is actually quite comforting for the patient. It's not something that I think makes me better. I think my patients, they like the fact that I am able to empathize and understand. But you don't need to be a runner to have an understanding of how the biomechanics works and to understand training principles and all of those things that many non-runners do for sure. But I would say that because I have done so much running and done it to a fairly high level, I definitely think it's given me a deeper understanding of how to manage a runner. Understanding a bit more about the type of strength training and the intensity they need to be doing, or, whether they've got a certain goal and how realistic that is, and ambition versus reality. And, I think it contextualizes a little bit more that sort of like load versus capacity. Like I know what it's like to run a marathon. I know what it's like to a certain time and progress to a certain time. I ran 2:39 in Milan this year, but that certainly wasn't my first marathon. So I understand what it feels like to progress. And I think that has been enormously beneficial. We've just gone through the spring marathon block and treating hundreds of runners since the start of the year. I do think has helped me, but I don't think you have to be a runner to be an excellent running physio.
Yeah, that's all good points. And I think you look at some coaches just across different sports. It's like you see great coaches that didn't participate in the sport. I think if you look at Bill Bowerman back in the day was an incredible coach, but I think he was a football player growing up. He never even ran.
Yeah.
But it does help, though, is what I hear you saying. It helps add context to understanding the training demands, how they're loading their body. I'm sure it helps with buy-in. And you're asking if you mentioned this injury to performance spectrum and getting your patients back with heavier load and stuff. I'm sure it helps with.
You're able to empathize. I think, running becomes a bit of when you self-identify as a runner, right? It becomes a bit of a part of your identity and, your social group. And it's, part of the thing that makes you. I think a lot of people who have come from someone, maybe they've come for a second opinion or they've ended up in my clinic room, telling someone who loves running not to run can be quite damaging for their sense of self-worth and all these things. And when you understand a little bit more about the demands of the sport, you often find that it's not no running. No running doesn't always help. No running's not always the answer. Sure, if you have something that requires complete rest, maybe it's a bone stress injury or something like that, then yeah, there's no running. But I think that if you don't understand the sport from that sort of perspective, it can be quite hard to prescribe the right amount of running.
Mm-hmm.
But not that you can't, but I think it becomes a little bit more easy to be able to to give an amount of running that helps the runner still feel like they're not losing that part of their identity, but also not getting in their own way.
Yeah, so I think maybe like a decade ago or 15 years ago when I first got into PT, you used to see all these patients that were just straight up told they need to stop running. I felt like it was a very common thing you would see runners being told. In your clinical practice, let's say, like, how often are you telling a patient, like, we need to shut this down completely and you're not allowed to run?
I would never tell them that they can never run again. Maybe that's a fault on my end. I'm a firm believer that graded exposure works, and finding the optimal load, I think, is part of the challenge and part of the fun. But I do also think it's really important to know when to stop, right? Like, pushing through someone's pain because they love running, that's them getting in their own way. So I don't often tell someone that they can never run. But, if I think of sort of clinical example that I've got at the moment, I've got a guy who has a really, really painful and bad bunion, that he's been dealing with for years and years, hasn't really ever done anything about it. And, his routine is that sort of Saturday park run. He loves it. It's a part of his life and his joy. But, he can't do it at the moment because it's just causing him pain. And, I've obviously given him lots of things that he needs to do for his rehab, and we've tried sort of redistributing the load with different footwear and more of a rocker and various other bits and pieces. So I'll always trial it. I'll always say, look, maybe we think of more of a run walk strategy or things like that, or maybe doing one of the loops instead of all of it, so you can still participate in the event. But yeah, I would rarely tell someone that they can't, but obviously I also am open-minded to the fact that I don't want to allow them to get in their own way. And when it needs to be pulled back, that's when your cross-training really comes into play.
Awesome. Yeah. So a lot different than what the runners used to experience. Yeah, like I said, a decade ago. Yeah.
So the runner class GP tells you that, running's bad for your knees.
So off air, you and I talked a little bit about your clinical philosophy. And one of the words that got tossed around was the biopsychosocial model. So would you mind diving into what that means for you in practice as you're working with a runner?
Yeah, so I think that running injuries are much more than the injury themselves, especially in the context of a runner. And there's lots that we can dive into there. But, with the biological aspects, you have the tissue issue. So, that's where you're looking really at that sort of load capacity issue, looking back through the training, understanding a little bit more about, the training errors that potentially have come into play. how they train, the strength training that they do or don't do, giving them a bit of understanding of, how tissue capacity works and helping them to understand a little bit more about, the actual impact that running puts through the body in terms of, joint specific and area specific. That's the sort of like the kind of classic MSK approach. This is the thing that we need to rehab. But that is not very holistic. It doesn't, you can't, it's not always a case of dealing with just the physical problem that they're presenting with. And actually, interestingly, more and more I see the connection between the sort of psychological and the social elements that have a massive impact on how that person is perceiving their pain. And, from the psychological aspect, there's lots of sort of like fear avoidance and, not wanting to use the thing that's injured and, the effect that sort of not running can have on your mental health. And, as I say, people will often self-identify as runners. Maybe it's part of their identity, it's their routine, it's how they use for stress relief and all those sorts of things. And I think all of that really needs to be considered. And then also you've got this sort of social element, like of, the stress that you have at home and the run clubs that you might go to and the social impact of it and like the fear of missing out. I think it can often really catastrophize and exacerbate a lot of problems. And I see it a lot with marathons, often when people are raising money for charity. They might have a cause that's really close to their heart. And I had a couple this year, and one in particular, she'd missed London Marathon in 2023 or 2024 due to injury. She'd missed it again in 2025 due to the same injury. And this time round, when she started a training block, the same injury had come back. And the physio she was seeing at the time referred her to see me. And actually, like, unpacking, yes, she had a problem, the biological issue that we needed to fix. She had patellofemoral pain, and there were, I put her through the Run Easy tech, and there were things that she needed to work on objectively, which we definitely did. But there was also a huge element of, I've missed the last two marathons. I've done this same thing has happened again and again, and the catastrophizing that has happened because of that. She also happened to be raising money for a charity that meant a lot to her, which, she lost her brother and she was raising money for that charity. They were relying on her and counting on her to sort of get through this and raise the cash. And that extra pressure and stress was so involved with her pain. And actually, once we had sort of identified that and sort of unpacked that a little bit and removed some of this sort of like pressure off of herself and fear, and was able to prove to her that her tissues were more tolerant, she was able to do more running. I think she'd only got up to maybe sort of 17 or 18 kilometers over the past blocks before having to pull out because of injury. Getting past that 20k, 25k, 28k mark was allowing, each time was sort of like green lighting, I can do this. And then she'd get a bit more sort of like stress relief and she can do the next bit. And it was not only about looking at increasing the tissue capacity, which is obviously a huge part of it, but there were just more factors at play. And I think that is something that I see a lot with runners.
Yeah, what I hear you saying is it's not one or the other, it's all of it. It's both.
You have your physical body, but above your physical body, you have your brain and your nervous system. You can't feel anything without your nervous system. You can't move anything without your brain producing the movement. So it seems nonsensical to me to disregard one.
What do you feel like is more common? Do people miss the biomechanics or do they miss the psychosocial component?
I'd say it's 50-50. It's really hard. That's a really good question. It's hard to give you a hard answer. I think when people miss the biomechanics is because I think they have misunderstood the demands of the sport and they have missed thing actually sometimes just quite basic. Maybe it's like a load management issue that they haven't quite managed to manage the load and the mismatch between just like strength training and impact. Right? Like you can be really strong concentrically, but not very reactive. And, you may have a repetitive calf sprain. The calf may be able to produce lots of power, but it might not be able to produce it very quickly or to be very reactive. And I think that sort of stuff does get missed and maybe misdiagnosed. You get the occasional thing there. But I think that the psychosocial stuff is missed quite a lot just because it's not really within the physio worldview. So you asked me how my practice has changed over the last 10 years and with regards to how I treat patients and even more so over the last 2 or 3 years, that element of the psychosocial has become more and more important in my practice, I think.
And the way you described it, working with that marathoner, is kind of that graded exposure back to running, but then almost like showing her or through experience, allowing her to see that her body is tolerating things okay. So you're almost reassuring her along the way, a lot of reassurance. Is that a good word for it?
I kind of tell them that it's like green lighting. You're green lighting that you can do this. Once you've run 5, then once you run 6, once you've run 7, like that graded exposure, you can call it what you like, progressive overload, graded exposure. But I think that really is understandable from a tissue capacity.
Yeah. So you're almost going back into the biological bucket and pulling something out of there to show proof that they're getting better, so that they can keep confronting things.
Absolutely, yeah.
You brought up Run Easy, but so like, where does tech or things like that come into play to help with that reassurance or validation or whatever?
Validation is a really good place to start. Someone says, my right knee's sore. So, you might get them on the treadmill and, put them with the belt on, or you might get them doing one of the jump tests, and you see the diminished score on that side. I think, sometimes they see that and they go, okay, I can understand there's a weakness there's a deficit on that side. And it gives them some sort of like tangible marker that needs to increase. And I think it helps therefore with validation, and it really helps with buy-in. If you give someone, I always say to people that exercise needs a purpose, or your rehab needs a purpose. And, you can, under the bucket of strength training, you've got force production, rate of force production, reactive, explosive, stability, all of these eccentric, all these different types of strength that you can build and power. And I think having markers for making objective markers where they can see that they can improve those helps buy-in and adherence, and also then feeds into that sort of psychological element of, being proud of myself. I've achieved that thing. Awesome. What's next? That sort of proof.
I just love how it's all like interconnected here. It's not one piece. It's all of this stuff blended together and using certain aspects to influence the other.
Yeah. Definitely that.
I was going to ask, so when clinically for you, as you went through this journey 10 years ago to now, I guess what made you switch gears and start approaching it more with this biopsychosocial approach?
Interesting. I think when you work with a lot of people and you meet as many people as you and I do, people fit into kind of categories, right? You've got people who are very nervous and very quiet, and people who are very like outspoken, and you meet so many different types of personality. And I think that there is a couple of types of personality that require more than just the physical side of your attention. There are a couple of personalities who are very much like, yeah, give me the exercises, let's go. But you also get there's a small subsection, there's a growing subsection of people who are a little bit more sort of nervous and anxious about their pain and their symptoms, and helping them to understand that that's involved. It's just something that I had seen quite a lot and was just interested in. And, social media being so good these days, these things pop up all the time, and you start to almost pull on a thread. You hear something, you watch something, you go, oh, that's quite interesting. I see that in practice. And you start to read around an area, and, you start to follow some good people in the space. And I think that that's where my sort of interest came from initially. And then I had my own personal experience of it really, really interestingly this year, in the sense that last year I trained for Manchester Marathon and unfortunately injured myself 8 days out, just overtraining and classic. And then 1 year later, I'd gone to train for Milan, as I did. And about 10 days before my race, I did my last session. And that evening I was having dinner, and the same problem started to appear on my other hip. And it was absolutely mental, because I'd just done a session. There was no pain during, nothing afterwards, but I could just feel this like very small background noise in my left hip. And it instantly reminded me of what happened to my right hip the year before. And I kind of was able to ignore it for about 5 minutes. I was like, oh, that's strange. But then it catastrophized so badly, so quickly, that I had convinced myself that I had done the same problem. I was going to miss my race. And that kind of classic paranoia, right? I was paranoid that I'd really done the same problem. I was going to miss the same thing again. And, the whole being a physio and an injured physio, and how it's bad luck, it looks bad for business. All these things pop into your head. The frustration, having put in all this time and effort into the training block. And, so I kind of had to sit with it. I was traveling to Rome, and I did that, and traveled to Milan. Even so, I told my wife that the night before the race, I was like, don't come and watch me from the start line, because I'm not sure I'm going to get very far in. I'm going to just go and see. So I walked to the start line. I had to jog across the road because there was a tram coming, and I was like, I feel my hip. So then I sat down in the pen. Everyone was warming up around me, and I was just like, this is going to go badly. Gun goes off, and I didn't feel a thing.
Amazing.
Like zero. Like, I felt I was checking it for the first kilometer and was like, is it there? Is it there? Is it there? And then just went. And that hip felt better than my other hip. After the race, during the race, it was like, it's not that pain was in my head. There clearly was a problem, but the problem was small and I catastrophized it. And there's also understanding that, during your training block, your cortisol's really high and it has an inhibitory effect on sort of what you feel. So then you enter your taper and the training stress reduces quite a lot. And, your cortisol as a result begins to reduce and you start to notice lots more things that are going on. And you become acutely aware and you sort of check and you scan your body. How's this feeling? How's that feeling? So that personal experience has only strengthened my firm belief in the sort of treat the person as a whole.
Yeah, I guess there's a lot to unpack there, but two things that I want to talk about is one, that personal experience that you just described has got to have like a tremendous effect on how you treat patients because you can talk to them about that. And that buy-in's going to be huge. And so that's where I think you do get a lot of benefit from having done the things that the runners that are seeing you are going through. The other cool thing, I've never heard somebody explain that. I call it like the taper tantrums. It's like during taper, I just got off a call yesterday with a runner I coach and she's experiencing some niggles. It's her races on Saturday. She's freaked out. But I do feel like that always pops up in those like 10 days leading into the marathon or the race. But I'd never heard somebody describe it that way. So you said, describe it again with the phenomenon, what's happening. Cortisol levels are high when you're training high.
When your training stress is super high, lots of things are going on in your body and, you're trying to adapt and recover. And one of those things is your cortisol levels are elevated just due to the training stress, especially if you're training at a high intensity. And then obviously you take a fairly dramatic cut in your volume and intensity. You might drop by sort of 40% in the first week and another sort of 30% in the second week. And the relative stress reduces fast and, you get the benefits of that in terms of, hormone levels and your system sort of chilling out a little bit. And then you start to notice things because cortisol has an inhibitory effect on what you feel. It dampens some of those pain. It has a slight analgesic effect.
That's really interesting. But then another important thing you pointed out there is that you said it wasn't all in your head, that there was actually some underlying hip issue here. It was just amplified because of your past experiences, because of the value that you were placing on that race and probably your identity as a runner, that you said your identity as a PT who treats runners. And I've been guilty of that too, where it's like, I'm a PT. I can't even get myself to the starting line healthy. What is that could look like for business? 100%. It's just a funny thing. But then in reality, it's like the experience that we as clinicians get from dealing with those injuries, I think speaks volumes clinically when you're working with a patient who's going through something similar.
I say it contextualizes that a lot. If you've had an injury or had an experience that your patient is dealing with and you've somehow managed to overcome it, I think it really does help to reassure people.
Yeah, to reassure them. And then you know what you're talking about. To piggyback off of that example of you leading into that marathon, dealing with an injury, we talked a little bit off air and you talked about it earlier today about like, how do you deal with a runner who comes into your clinic and they're 3 weeks out from their goal race and now they got an injury and they want to race? How do you deal with those runners?
You have to deal with the runner. It hugely depends on the injury, right? Like, if it's a non-starter, it's a non-starter. But there are many people who come in that, the marathon really peaks in intensity and volumes around those sort of 6 weeks out, 4 weeks out, 3 weeks out. And, as the people are going through their peak mileage weeks, and that's a lot of the time where people run into tissue capacity issues. So you need to understand how they've trained and how long they've got left. You need to look at sort of, whether they need to build some fitness, whether they can actually do any running or whether they have to go solely onto cross training. But I think this is where sort of understanding like the training principles then becomes really useful. Like if that person cannot run because they've got a problem in their hip that means that they can't run, can they cross-train on an elliptical? Can they cross-train on a bike? Are those two things pain-free? I often explain to them that, they're not the same, but your heart hasn't got a clue what you're doing. It knows beat fast, beat slow. So you can still do threshold work. You can still do VO2 max work. You can still build an aerobic base on a wide variety of equipment that doesn't stress your injury, which will allow your injury to relatively settle and calm down, and you do your rehab alongside that as you do. But you don't have to derail your fitness. Yes, you might lose some of the neuromuscular sharpness and coordination because you're not running regularly. But if that person's got time to settle the injury, replace those runs with effective cross training, and then do a few runs in the lead up to it, that's a perfect situation. And I've seen that countless times over the last 6 months, over the last 5 years, where some of these injuries, again, they're catastrophized. So if they're not as bad as they may seem, that person may need a little bit more of the sort of psychosocial help. And if the injury is bad enough that they can't run, but they can cross train, but will settle in time, often it's just knowing when to course correct and convincing them that actually you don't have to run loads to maintain that fitness. A short succession in your running, you're not going to lose any meaningful fitness. You're going to lose sharpness, and that comes back fast.
How do you deal with the confidence issue? Because I think that is a big, when a runner gets injured that close to the race, and you're telling them they need to cross, or they can cross train to kind of maintain that fitness. Yeah. I think one of the big hits that I see that the runners taking during that is a hit to their confidence. Like, oh my God, I can't run. I'm not going to be able to do this race. I don't care if I can stay fit on the bike. Like, how am I going to do this? How do you deal with that?
It depends on the type of runner that you've got. If you've got someone running their first marathon who's not goal orientated, it's a little bit easier. If you've got someone going for a specific goal, and that then you're juggling the ambition versus the realism. Sometimes you have to be quite firm in the sense of you're no longer training for a sub 3 hour marathon because you've missed 4 weeks of your training block. Your training plan has gone to plan. You need to have an understanding of adjusting your goal. But, let's say you get one of those good examples of someone who's done really good training and, you can get them back on track. I think storytelling is really a really valuable way of communicating, and being able to reel off the genuinely countless stories and examples of cases like this, I think can be reassuring, using either personal experience. I've had niggles and things and had to miss workouts. Even in this block, I had a small irritation of my hamstring. I did a half marathon 5 weeks out, and then did a big fat marathon workout the week after, and my hamstring was a bit sore. So then I missed my hard workout the following week. I cross-trained instead, and then was able to carry on the week after. So I think storytelling, personal examples and examples of similar people is really important for that.
Yeah, just showing them examples so that they calm down a little bit. You're trying to talk them off the edge. I'd like to take a moment to thank our sponsor, RunEasy. RunEasy is a running and jumping analysis tool that helps provide objective data on things like impact loading, dynamic stability, and symmetry. I've been using it in the clinic for the past 3 years, and I love how easy it is to add to my evaluations. Not only that, but it backs up my clinical reasoning and helps me with my decision-making process when I'm doing exercise prescription. So if you're a physical therapist or running coach, then book a demo. If you're lucky, it will be with me. If we go back to your influences, so you said over the past decade how you've changed, but were there mentors you had along the way that helped you through this process, or clinicians, courses or books you read?
Again, I get a lot of information. Having been self-employed for so long, there are people who I follow online and whose courses I've gone on. I was going to say even people like Jack Daniels is probably one of the, in terms of training principles, following Jack Daniels, reading, I've listened to Jack Daniels, his training principles book a couple of times. It's a great one if you're on a long run. So people like him, I use the style, the training principles sort of concepts, I think is really good. People like Tom and other physios who are really good. There's lots of podcasts out there, but also just other people who are maybe slightly less known within the sort of strength and conditioning world, and just other physios. There's some really amazing content on social media that you can really pick out some really good bits, and that can drive curiosity for you to read and to learn more.
Yeah. Speaking of social media. You have quite the following on social media. How big of a role does that play in your business?
It's helpful for sure. I definitely get quite a few patients through it. So it's definitely a very useful business tool. But I don't really class myself as I'm not an influencer. You're not going to catch me, come with me on my day whilst I do this thing. The content that I produce and post is a little bit more sort of like educational. It might be a video of someone running on a treadmill and being like, what can you see? Or look at this person's hip and look at this crossover gait. And, this person's been dealing with IT band syndrome or whatever it is, and kind of giving a little bit of understanding around sort of like low level biomechanics sort of stuff to people, and strength and conditioning rehab specific to runners, and, information around, fueling and how people kind of mess those things up. So it's more educational content rather than sort of like, I'm an influencer, follow me because I'm amazing.
Yeah. And when you say educational content, are you gearing it more toward the injured runner, just runners in general, physical therapist?
Runners in general, I would say there's definitely content for injured runners. There's content for those that are not injured that want to increase their performance and just kind of enjoy it. So I think that's a fairly wide spectrum of it. But of course, social media, it's a bit of a game. I can post content that I think is really valuable and information heavy and really useful, and it can get terrible engagement. Whereas, I can post that I ran a 2:39 marathon or a 1:12 half marathon and get 500,000 views. So there is definitely sort of there's that sensationalism, like they call it runflation. The standards of running have come up so far, and because I'm a normal person, people go, oh, he's a normal person. How's he run 2:39? I want to, and it's not normal.
Yeah. It's such a hard code to crack for like small businesses. It's something that I haven't done a good job with personally. But yeah, that's for another day. If we go back to you in the clinic, I'm just curious, what kind of cases are you seeing a lot of right now?
Lots and lots and lots of tendinopathy. That's probably the most common that I am seeing at the moment. Proximal hamstrings, Achilles, patella, seeing quite a lot of tendinopathies. As all running physios, you see a lot of patellofemoral pain. That's quite common. A lot of glute tendon stuff. So, but I think at this very moment in time, because now the racing season has sort of curtailed slightly, I'm seeing a lot of people who maybe were dealing with a niggly tendon during the race, did the race, didn't recover quite enough afterwards, and have now kind of crossed the threshold. Whereas if you had asked me 6 weeks ago, it would be a lot of sort of like urgent care marathon pre-race help me situations.
Yeah. And then what does treatment look like for you when you see one of these tendinopathies?
First things first is always load management and sort of education. I think, again, that's something that, changes when research comes in and kind of changes how people view things. And tendinopathies, I think, is a big one, changing from tendinitis to tendinopathy, because, the inflammatory markers in a tendon when it's inflamed are not the same as if in your tonsils when you have tonsillitis. So they change the itis to tendinopathy. There's a little bit of more neural nerve involvement. So I think education around tendinopathies is really important, and helping people understand the sort of process it goes through. It starts off as normal. You might get excessive tendon load. You might get a reactive tendon, or, end up with tendon disrepair or degenerative tendon. But all of these can come back up to a normal tendon. You want to end up in that cycle of like optimized load and adaptation and getting stronger. So I think helping people understand that wherever they are along that journey, they can get to somewhere is really good, but also really, really managing their expectations in terms of time. Tendons are load adaptive. They need strain to actually get better. So helping people overcome that sort of fear avoidance of triggering that pain, explaining to them that the strain is necessary. It's not going to be pain-free, but as long as it is well managed and controlled. But that time frame context, I think, is super important. There's this graph that is basically, I may as well have a printout of it on my wall, which has different type of tissue in the body and how long in terms of weeks, so that you start to see meaningful adaptations in them. And, things like your nervous system is super fast, and then your muscle tissue and bone, and it starts to come like fascia, and they start to get, ligaments, and down at the bottom are your sort of tendon and cartilage, because they just take a long, long time to adapt, if they're going to adapt at all. And I think that is sometimes helps people managing their expectations. They might have a full-blown Achilles tendonitis and they still think they're racing next week. So I think the first port of call is always load management. Let's settle that thing down, because otherwise your rehab's not going to be accepted, helping them really understand what it is, the type of tissue that it is. Sometimes I go into quite a lot of details, helping them understand that, the tenocytes, the little cells inside the tendon, they need encouragement, and it's strain that produces the adaptation. By getting them to lay down the collagen, it does it slowly, sort of helping them manage the time frames. And then I will work through various different things. For some people, they need isometric work so they can load the tendon without causing too much irritation or bite back afterwards. And that's if it's quite inflammatory, then I might move them to some sort of eccentric and build them up to plyometric stuff. But sometimes you get one that's actually not so bad, and you can actually do a little mix of the two. You might start them with a bit of isometric, but already kind of move them onto the dynamic eccentric stuff quite quickly, and then just impress upon them the importance of progressive overload, that, that tissue being load adaptive, it needs more and more and more load. And then the stuff needs to be sport specific. And that's where the elastic recoil or the energy store and transfer of plyometrics and the reactive strength comes into play. And especially if you want to start running again and you want to take lots of plyometric steps thousands of times, you need to include some of that in your rehab.
Yeah. So you kind of lay the foundation. The foundation is the education and setting the expectations that this is not going to be instantly better, that it takes time. Tendons take time. I think Chris Johnson said that. When you are in that mode, you're educating the patient. What do you tell them timeline? They got a cranky Achilles. What do you tell it?
I typically don't tell them timelines. I actually try to I often tell them not to worry or not to focus too far in the future. I kind of tell them, let's go 2 week by 2 week, because actually if you focus about how long something's going to take you, you're going to struggle to remain consistent. You're going to get frustrated. So I pull away from giving them timelines, but I often tell them that it's months instead of weeks. And I think that is good to understand, but also it's important for them to understand that it doesn't have to be pain-free for you to start running again. Your body doesn't have to be pain-free. You are allowed to be nursing a niggle or an injury and have a version of running within your life. That's the sort of whole load management, right? It might be very little running at the beginning, but let's say you've got someone who's just been able to start tolerating all their eccentric stuff and their range of motion is actually quite a lot better. Let's say it's a proximal hamstring tendon, and actually they've been doing some very gentle plyometrics with the legs under the body, so there's no load really going through that proximal hamstring. But you go, okay, well, you can't sprint right now, but actually if we increase your cadence and shorten your stride, get the foot under the body and maybe start you with 2 minutes on, 1 minute off 5 times, we can start to use the graded exposure of running as your rehab. So I tried to not give them time frames. I tried to have sort of milestones of kind of reintroducing and tried to get a version of their running back in as soon as I can. But it's important to explain to them that the version of their running is maybe different to what they are expecting it's going to be. A lot of people think the smallest run you can do is a 5K. But actually, a walk jog interval for someone on that return to run from a tendon is where they have to start. 25 to 35 minutes might be way too much for that tendon. You're just going to exceed the capacity and flare the injury.
And there's something you said early on as you started talking about this about 2 week snapshots. So tell me about that.
So again, I try to get them to think of it in sort of shorter time blocks rather than to have them focus on the end goal. Even when I see these patients, unless someone really needs to be seen really, really frequently, it's the work they need to do. So I don't typically try to over-treat these patients at the beginning. I don't try to see them weekly. I try to see them close to weekly, because actually what I find in experience is they need to have done enough of the work to start to notice any of the improvement. Let's say you've given them some isometric stuff to begin with, they have an inhibitory effect. So they're trying to dampen some of the pain signal and start to get some strain through the tendon. But if I see them today and then see them next week and they've only done them 3 times or maybe 4 times in the interim, they are going to come back into that session probably feeling slightly disheartened. And actually longer frame time there, maybe by that sort of 6th or 7th time they've done them, they've come and seen you on that 2 week time. They start to understand a little bit more about what they're likely to see.
So check-ins help set expectations. I often tell people, we get in the habit of judging progress day to day. And for some of these pesky tendinopathies, it's you fall into a trap of just feeling like you're not making any progress when you do that. But if, like you say, you zoom out and we say all right, how do you feel 2 weeks from now. Like, that's what I care about. And then 2 weeks from that. So you have this like rolling 2 weeks. Every 2 weeks, you're just checking in. Have I made progress? And sometimes progress looks like the pain is exactly the same, but I'm doing more now.
I think that's a huge one. That is a principle that, again, I have to explain to people all the time. It's like, if your pain is 5 out of 10 or whatever it is, and in 4 weeks' time it's still a 5 out of 10, but you've gone from it coming on at mile 1 to it coming on at mile 10 or mile 5, you've gained all that amount of work for the same amount of discomfort. Pain isn't attached to tissue damage. There's no exact, you're this damage, you're in this pain. It's very perceptive, and you've got to understand the biopsychosocial model as well. These people might be missing out and are worried and fearful. So it all comes into play again. But yeah, I think that's a huge one, is helping people understand that actually getting the pain but doing more to get it is a really brilliant way to progress.
With these tendinopathies, you've talked a lot about load management, education. Where does something like a gait analysis fit in for those patients?
It wouldn't really fit in until I have got them back into running, mostly because it would just give me invalid data. So, if you've got someone with a painful, proximal hamstring tendon, and they can't stride like they would normally, or they've got an Achilles problem and they decide to redistribute the load more towards the back of their heel, it doesn't really come in my opinion, until that patient is able to run. And you can either then do one as a benchmark and then one in a sort of 4-6 week period time afterwards. And that can be quite nice, because, again, as long as you kind of use it with your other testing as well, get some objective data. But I think, it's not very useful diagnostically, whereas with other issues, it can be quite a useful tool diagnostically, especially with stubborn things that are, don't present in like typical ways. But yeah, so with these, gait analysis comes a fair bit later down the line for me.
And then once they reach that point where you decide, I want to take a look at your running, are there specific things you're trying to look at when you look at their run?
Again, depending on what issue they've got, but how I do gait analysis, I do a sort of like top to bottom approach. I look at sort of like head position, whether they're vertical oscillation or bobbing side to side. I'll look at sort of shoulder rotation, trunk rotation, arm swing, whether it's whether there's any compensation or asymmetry or any particular direction of movement. Obviously, looking at your pelvis, your sort of drops and differences there, or trunk shifts across knees, feet, ankle. I kind of do a sort of like back view, and then I'll always do a sort of side view. I always film when I do. I will always use filming and the device. I like to have the sort of multi-view option. But, then it depends a little bit about what the problem is. If it's an Achilles, whether they have the calf capacity and how they push off, how much hip extension they get, and, how much they are using or where they strike their foot on the ground. If it's a proximal hamstring, things you're looking at might be a cadence issue, might be an overstride issue causing compression in the sort of early stage of swing phase. So yeah, it very much depends on what the problem is that you're dealing with.
Some of the things you described, though, sounds like maybe looking for clues into how they're loading or overloading the cranky tendon, depending on the location.
Definitely.
And then you're tying in both visual data with slow motion video and then some tech with Run Easy, and then kind of put all those pieces together.
Yeah, often I'll sit down then with the patient, I'll have the data, the Run Easy data, and I'll show them the video and I'll slow it down and I'll screenshot it and draw lines on for them if they need it. And just so again, education becomes hugely important there. People are often just not aware that they're doing these things. The overstride is a classic one. People don't feel the overstride, and they don't necessarily someone, are you a heel striker or a toe striker? They'll go, I don't know. And it's not because it's just because they're unaware. It's not because they don't know what they're doing necessarily. They just have never really thought about it. A lot of people who run have just kind of picked it up. They're not runners. They're not elite training people. These people have just sort of begun running as a hobby and maybe gotten better at it and done it for 5, 10, 20 years without any thought other than just like, I'm going for my run now. So I think helping people understand biomechanics, is really interesting. And like some of the compensation patterns you see are so interesting. There might be a trunk shift out to the side and an arm comes out to the side and they can't feel that. So, they're landing on the leg and they compensate, but all they feel is just running.
So you use that, you'll show them that and kind of educate them on this is how you're compensating.
Yeah. I think it's important to help them. The body has natural load redistribution sort of these are subconscious, right? Your body won't naturally just let you run into pain, and that sort of pain in an area will cause a subconscious shift off of it, an unloading pattern or a loading pattern. And I think those are quite useful with sort of like chronic injuries as well. They're really good, and like helping people identify, less so with tendons, but like an issue that someone's had for years and they've maybe tried lots of different therapies and physios and bits and pieces, and they can run, but they don't know why at 20k this problem always starts to appear. But you could begin to show them that actually they've got this quite subtle load redistribution pattern and compensation that actually after 20k's worth of volume has been done 15,000 times, and they're like, yeah, it makes sense. It's the capacity of that has been reached.
Yep. Yeah. And we talked a little bit off air about, I think, one of my patients where it's like, yeah, using data like and tech like Run Easy, where you can kind of show the patient, like, to validate that experience that they're going through. Like you have chronic right hip pain or right leg pain, and I can show you with data and some visual stuff that you are loading that right side differently.
Yeah.
So that's tendinopathies. I guess one last question I have for you. What are like some of the hardest cases that you see in the clinic? Are they, if it's, you're seeing a lot of tendinopathies, I'm sure we see a lot of bone stress injuries, but are there any patients or type or cases that you kind of feel like are just really hard?
Sometimes you can't tell where the pain's coming from. There's the odd occasion where something's just very unusual. They might get pain. Like I've got a case at the moment that's quite interesting in the sense that she has a sort of lateral knee pain, and it only comes with running, and it doesn't take much at all to bring it on, but she can do loads of other things. She's had MRIs, everything's clear. It's not an IT band issue. It's not a fat pad issue. It's not a meniscal issue. And so like everything is clear on scanning. She's tried several different physios. I'm like the third person she's seen. And so you sometimes you just get a real head scratcher where it's like, it's not obvious. And I think they sort of, and I've only seen her once, I'm seeing her again next week. And one of the things that I remind myself is like, some issues require turning over more stones, right? So like some things are dead obvious, right? A lot of our job is pattern recognition. You've got a training error, tissue capacity, you've done something silly, simple. But you do get the occasional person that is just presents abnormally, and pain that can be referred or transferred from other things. And actually, she's done a gait analysis and we did some strength testing, and actually she scored really well, but she just had this pain. So I think that the ones that kind of stump me are those ones, but that's going to require me to do a lot more objective stuff and subjective digging and kind of, so we're going to go through a lot of her sort of like training history together in more detail, and the strength training. We're going to go over a lot of her technique with the exercises that she does. And, we're going to look at her running again and sort of like see if we can trigger that pain and sort of like really kind of get to the bottom of it. But yeah, I think so. Those ones are trickier.
Yeah, where it sounds like a lot more uncertainty involved in that case, where the scans come back clean. Yeah. She's probably more stressed about that because it still leaves all this uncertainty as to what is actually going on. Yeah, at what point with a case like that do you say, like, man, we just got to start get you moving?
That's what she's doing. That's what I have kind of instructed her to do this week. It's like, let's sit with that pain. Let's actually get you moving. Let's get you running, and let's see how bad that pain actually gets. During a couple of runs this week, we can, and see if the pain develops the more you push it, just to kind of see if we can really get to the bottom of it. But also, I'm not afraid at all to sort of bring someone else in. I think sometimes getting another pair of eyes can be really useful. So there's a couple of physios that I might consider sort of asking to take a look if I feel like I'm not quite there with it. And there are those that are, more biomechanics focused, more psychosocial focused, combination more focused. So I like, I said to this person that, we'll get to the bottom of it. It might, we'll turn over all the stones, but we'll get there.
And don't be afraid to ask for help is what I hear you saying, if you feel like you need to.
Definitely. I've been self-employed for 7 years, and, I a lot of pride in sort of being able to do a lot of things on my own, but actually you can't do everything on your own. And actually it's only really when people started asking me for help, I was like, oh yeah, that's actually a really good idea.
Yeah, no, it's one of the pros and cons about being self-employed. Yeah, it's like you're in it by yourself, and sometimes it's nice to have those other clinicians to reach out to and to bounce ideas around.
Yeah, definitely.
Well, Ben, I want to be respectful of your time. It's been great. I really appreciate you coming on here, talking to us about all things running related physio. For the listeners that want to learn more about you, where can they find you?
Find me on Instagram at Ben Lombard Physiotherapy. And if you are in London, you can find me in Finsbury Park or in the city.
Awesome. Yeah, well, go check Ben out. Follow him on Instagram. And till next time.
Yeah, thanks so much. See ya.
That's it for today on the Physio Insights podcast, presented by Run Easy. Would you like to share an interesting case, insight, or have a thought about the podcast? Comment below, and don't forget to follow us for more episodes.